Spot on open clinical trials in soft tissue sarcoma, GIST, and bone sarcomas. My name is Denise Reinke. I am a member of the board of directors of SPAGN, and by way of background, I'm a sarcoma nurse practitioner, past president of SARC, an academic research consortium based in the United States, and also was a founder of the Sarcoma Coalition, which is a patient advocacy group of groups within the United States. And so I'm so delighted to be a part of the SPAGN board and the work that SPAGN is doing to bring together our international community of patient advocates. And we're so delighted today to have so many people interested in joining us for a conversation around clinical trials. Clearly, clinical trials are so very important in helping us to identify new therapies, to improve outcomes and give more opportunities for individuals facing sarcomas. And we have two incredible experts with us today who are going to share updates on where some open clinical trials are. Oftentimes clinical trials can be a good choice and people don't know where to find them. So it's so nice to have this conversation today about the clinical trials that are currently ongoing in soft tissue sarcoma, GIST, and bone sarcomas. So I'm delighted to initially introduce to you Dr. Nathalie Gaspard. She's a pediatric oncologist at Gustave Roussy Center campus in Villef in France. She's in charge of bone sarcomas as well as cancers that peak in the adolescent and young adult population. And she has interest across the basic scientific biology as well as to clinical care. And Dr. Gaspard is going to be talking about clinical trials in bone sarcomas. And we're also joined today by Professor Robin Jones, who's a medical oncologist, and he has a special interest in bone sarcomas and soft tissue sarcomas. He's been a principal investigator on a number of clinical studies across the number of phases. There are different phases of studies, phase 1, 2, and 3 clinical trials. He's a consultant medical oncologist and reader at the Royal Marsden in London, in the UK. And Dr. Robin Jones will be speaking about open clinical trials in soft tissue sarcoma and GIST, and that will include desmoids as well as giant cell tumor of bones. So without further ado, I'm going to turn over to Dr. Gaspard and ask her to share with us about clinical trials in bone sarcomas. Thank you.
And I'm very pleased to, and I hope my talk will be what you expect, because it's more an overview on how to think about clinical trials and those that have failed, those that have succeeded, and those that are ongoing and will be set up soon. Can you see my screen?
Yes, we can see your screen very well.
Okay.
Thank you.
Then bone sarcoma is a vast, different disease, which I will not talk about all of them today. I will talk most of all of two sarcomas that are the most frequent in the adolescents and young adult population, which are osteosarcoma and Ewing sarcoma. And just to remind you, that's a very rare disease. If you look at the incidence of these bone sarcomas. The presentation is very different between osteosarcoma and Ewing sarcoma, which probably reflect also a different biology, even if they are both occurring on bones, with an osteosarcoma that have a very chaotic genome and a lot of structural alteration, while very few mutation, and Ewing sarcoma, which is supposed to be a simple genetic sarcoma in a way that he has a driving fusion that is responsible of it. But despite that, the general schema for bone sarcoma treatment is the same. It has to be in a multimodality treatment. It's a multimodality treatment that should be done in the expert center. It starts at the time of the biopsy, because if you jeopardize the biopsy, you risk to jeopardize also the local treatment of this disease. They include chemotherapy, neoadjuvant chemotherapy and adjuvant chemotherapy, a local treatment with surgery, and radiotherapy for Ewing sarcoma, not for osteosarcoma, usually because they are chemo-resistant. And there is clearly a need to improve the control of the metastasis to be able to improve the outcome of this patient. And there is also a risk of long-term sequelae that is important with the current treatments, especially in growing organism. Then how to introduce new drug to increase efficacy and to not increase long-term effects or even reduce long-term effects is something that is very important in both bone sarcomas. They are very hard to treat disease, with the main problem being the presence of metastasis and the resistance to chemotherapy. And this is both prognostic in both osteosarcoma and Ewing sarcoma. When you have a localized good response, the prognostic is around 80% in both. But if you have metastatic disease or multimetastatic disease or metastatic disease and poor response, then the survival is very poor. Up to now, chemotherapy has been exploited probably at best, as we do it now. And it has been done in first-line trial in large collaborative multinational trials. In osteosarcoma, it was the EUROMOS trial, which was a worldwide trial, where they tried to introduce to the usual MAP chemotherapy, which is methotrexate, adriamycin, platinum, IE, with no improvement. But over the world, there are also other regimens that are used rather than the MAP. In the Ewing sarcoma, we have shown the importance of the dose intensity of the chemotherapy, either in the Euro-Ewing 99 trial, where high-dose chemotherapy was shown to be important for patients with localized poor response over the conventional chemotherapy. And the American trial have shown that VDCIA compressed in 2 weeks was better than doing it in 3 weeks. And comparing both European and American chemotherapy, the VDCIE has become now the standard of care. There have been several trials to try to improve that chemotherapy, and up to now it has not been efficient. Due to the biology of the tumor, several attempts have been done in both tumors to try to modify the microenvironment and target this microenvironment to improve survival. In osteosarcoma, immune therapy has been tried with the MEPACT and the interferon alpha, but also targeting bone vicious cycle with the zoledronic acid, and all these trials have not shown increased efficacy. In Ewing sarcoma, the zoledronic acid has also been tested with no added effect in 2 trials, in VDCI in the 2 trials, one just in localized disease, the Ewing 2008 trial, and one with all kind of disease, local or metastatic, with the Euro-Ewing 2012 trial. In relapse, there is no clear standard of care. In osteosarcoma, which is very important, is to be able to operate the disease, because that's the most important prognostic factor at relapse. Chemotherapy is often used, but there is no standard regimen, and more recently, multikinase inhibitor has shown some efficacy. In Ewing sarcoma, there is a clear interest of chemotherapy, and these diseases are very chemosensitive, but usually not curable. And the RECURE trial has shown that, has compared different chemotherapy regimens, and is now also trying to introduce multikinase inhibitors. The multikinase inhibitor has shown clearly a class effect, and we have got a meeting 1 year ago with all the bone experts discussing about the multikinase inhibitor in both osteosarcoma and Ewing sarcoma. And clearly, there is a class effect as single agent in terms of efficacy in relapsed primary bone sarcomas. But all these trials were mainly adult patients, heterogeneous disease at presentation, heavily pretreated patients, mainly measurable disease according to disease, leaving outside this trial all the patients with just evaluable disease but not measurable disease. There were very few objective response and unknown long-term toxicity, in particular in the pediatric population. Then the conclusion of this strategic forum from Accelerate was that a safety profile was okay, but there were a need of a biomarker and the need to discuss how to pursue the exploration of this multikinase inhibitor in bone sarcoma. And since then, there have been several trials that have shown also the feasibility of this multikinase inhibitor with some chemotherapeutic agent, especially etoposide isofosfamide in the HOPE trial, but also with adriamycin, but no trial with methotrexate or multi-drug regimen at the same time. In terms of efficacy, there's still to be proven that adding a multikinase inhibitor to chemotherapy is useful for the patient. Here in the HOLY trial, we have shown no increased efficacy, even if the lenvatinib plus chemotherapy arm was a little bit higher, the curve was a little bit higher than the chemotherapy alone. And that was in a study. And one of the problem that we faced is that there were more patients in the chemotherapy arm alone operated of the metastasis than in the chemotherapy plus lenvatinib arm. And we don't know if it's because there were a reluctance from the clinician to operate under multikinase inhibitor because there is a risk of wound healing problem, or if it's because the clinician have pushed more in the chemotherapy arm to the surgery, which is the main prognostic factor in osteosarcoma, because they knew that the new agent was not given to the patient. Then that's something that is very important because from that, we learn that the trial design is very important and the decision of the doctor is also very important. Then how to introduce these multikinase inhibitors in first-line therapy? This is the question that asked at the moment in bone sarcoma. In the Ewing setting, there is a REGO anti-Ewing phase 1b trial that is ongoing, trying to add multikinase inhibitor, in particular regorafenib, to the VDCIE chemotherapy from induction for all the duration of the treatment. At the moment, there is 2 patients in treatment. If this is only for metastatic patients, and if the feasibility, the tolerability of this association is proven, then it will be introduced in the next first-line trial in Europe, which is the Euro-Ewing Consortium, the anti-Ewing 1 trial, where the first question will be for all metastatic patients and not just for the multi-metastatic patients, in a randomized way, to understand if the addition of multikinase inhibitor is adding efficacy to the treatment. There will be other questions asked, and which is very interesting is that we will have also a local treatment question in that protocol for either a dose escalation question on radiotherapy for patients that are not operable and will have definitive radiotherapy, and a de-escalation radiotherapy for patients that will receive radiotherapy post-operatively. The last question is a maintenance question, and as all the Euro-Ewing trial, there is biological marker and imaging biomarker studies attached, as well as quality of life studies. And this is a consortium that is ongoing in Europe since already 10 years. And all the last study have been done through them, either at diagnosis or at relapse, with important biology questions. In osteosarcoma, the story is a bit different, because since the EURAMOS-1 trial that closed in 2012, there was no collaboration in Europe. There were several national initiatives with different national trials that are ongoing. Only one of the trials that you can see here are specific for osteosarcoma, which is the Sarcoma 13 trial, asking the question of mifamutide only in patients with high risk, means local patients with poor response or metastatic patients. All the other trials that are present here are trials that are not specific to osteosarcoma, or either for all bone sarcomas or for all sarcomas. The Immunosarc-2, which is testing PD-L1 with chemotherapy, and the REGOMAIN and the REGOSTAT study that are testing multikinase inhibitor in the maintenance treatment, or metformin trial that is testing the repurposing drug, which is the metformin in maintenance too. Due to the fact that there were no European collaboration, there were also no common biology study. Even if there were sample collection and studies that were at national level, there were no coordination at national level. This is why we have created a new consortium, which is FOSTER, for Fight Osteosarcoma Through European Research, which is an open collaborative consortium, multidisciplinary, multi-regional, with expert senior and young investigators, multinational in geography, with the geographic Europes. And from the beginning, we wanted to associate patients and parents to the consortium. There is currently 20 countries to more than 300 members, and we have 9 work packages going from biology to clinical trial, but also to image question, local treatment question, quality of life, and also predisposition syndrome to osteosarcoma. And data sharing and knowledge dissemination is a part important of the consortium. In osteosarcoma, multikinase inhibitors are also introduced in first line. There is already an open trial in the US where they are testing the cabozantinib in combination with chemotherapy from diagnosis. This is currently a single-arm feasibility phase 2 trial, because there is a fear of the toxicity of the cabozantinib associated with the chemotherapy, especially with the methotrexate. And with the surgery, because there is a risk of wound healing. And if the phase 2 succeeds, then there will be a randomized phase 3 trial with 4 parallel efficacy arms, 2 for the localized disease, 2 for the metastatic disease. And for Foster has decided to do it a little bit differently and to introduce multikinase inhibitor in the same cabozantinib, but only in maintenance treatment, with 12 months maintenance treatment in a randomized phase 3 trial, whatever the age of the patients and the disease. And they have decided to randomize multikinase inhibitor versus placebo. And the things that is important is also to introduce biological stratification factors in this trial, as up to now there is no stratification on biology. And how to use biology to inform clinical trial, that's an important question from the current and next trials, especially in osteosarcoma, but also in Ewing sarcoma. It can help to choose the drug, to stratify the patient at diagnosis or relapse, to drive the therapeutic at diagnosis and at relapse, and also to better understand the mechanism of resistance of the new therapies. And with the new tools that we have now, we can separate also the knowledge on tumor cells and tumor microenvironment. As an example for osteosarcoma, we know that there is some genetic abnormalities that can be targeted with a proof of concept in patient-derived xenograft in vivo models. But up to now, there is no huge impact on the for patients that have been use molecular-driven treatment. The goal will be to have biological stratification of osteosarcoma. We are starting to have some with different publications that have been published this last few years. We need also to learn how to use liquid biopsy to better inform our trial. Late effects are also important, and there is some late effect that we know very well. But what about the new drugs and following up on this late effect of new drug? That's also something that is very important for patients. This is why in Foster Consortium, we have tried to set up a full program that goes from host predisposition, clinical trial, and up to late effect with different biological imaging and local treatment questions. And as patients' thoughts are very important. They have a huge knowledge on what they are facing. We try to help patients to express what they want. And with Foster patients and parents group and other patients and parent groups, this survey has been set up, and I hope we will learn a lot from that. Then we are moving now from multimodality treatment in expert center with chemotherapy, surgery, plus or minus radiotherapy, to better definition of how to treat patients. Essential tumor and host biology to be implemented in each trial, and new drugs at the moment, multi-kinase inhibitor, to be implemented in these trials in different ways across the world. And these complementary trials will help to quickly answer the role that we should give to the multi-kinase inhibitor in first-line treatment of bone sarcoma. Thank you very much.
Thank you so much, Dr. Gaspar, for giving us a real good overview on where things are at in bone sarcomas and clinical research and some of the challenges. And I would ask that you kind of save your questions to the end, and we're going to have Professor Jones talk to us now about soft tissue sarcoma, and we'll be happy to entertain questions when he's done with his presentation. Professor Jones?
Thank you, Denise, for the kind introduction. And it's really nice to see everybody today, even if we're not face to face. And thank you to Catherine and the team for the invitation. So these are my disclosures, and this is quite an extensive topic. And I've tried to split this up into different components. And given that there are many clinical trials open to patients with soft tissue sarcomas and GIST, I want this to just be, in a way, a flavor of the trials that are open. And it's by no means an exhaustive list of the current trials that are open. And I think, following on from Denise's introduction, one of the major things is that it's important to think of clinical trials as a treatment option in terms of treating particularly metastatic sarcomas, and to be strategic in terms of using clinical trials as a component of treatment, maybe even leaving standard treatments in reserve for after participation in a clinical trial. So I've decided to focus on several different topics. The first, neoadjuvant or pre-operative treatment. The second, GIST or gastrointestinal stromal tumors. Then some of the trials that are ongoing for leiomyosarcomas and liposarcomas. A little bit about immunotherapy, an overview of some of the other trials, and then also the trial, a randomized trial that's open for desmoid tumors, and then finally a conclusion. So starting off with preoperative treatment and preoperative trials, I think for us in Europe, one of the major trials currently is the current EURTC trial, randomizing patients with operable lipo and leiomyosarcoma of the retroperitoneum to either receive surgery or to receive preoperative chemotherapy followed by surgery. And you can see from this slide that the chemotherapy schedules are different for lipo and leiomyosarcoma. So for liposarcoma, it's 3 cycles of doxorubicin and ifosfamide, and then for leiomyosarcoma, it's 3 cycles of doxorubicin and dacarbazine. And the primary endpoint of this particular trial is disease-free survival from randomization. So the time that it takes for the disease to recur after randomization into the trial. So a very important trial led by the EURTC. So on the background of this trial, we also got a consortium between centres in Spain, Italy, and the UK, trying to link in the basic laboratory research into certain sarcoma subtypes, and also the clinical research in terms of surgery, radiology, oncology, and pathology. And this consortium is looking at patients treated with preoperative chemotherapy before surgery to try and understand the ways that drugs work in certain sarcoma subtypes, and also to understand why drugs don't work for other patients. And this is quite an ambitious project, as I say, an international project, and Gerard and Roger, amongst others, have been very helpful in terms of the steering committee for this project and guiding us in terms of the research proposals. This is an outline of the design of the project. So we plan to have 3 different programs that link into a 4th program. These programs include data collection and management regarding clinical data, the pathology data, as well as the radiology, and then profiling the tumors, as well as conducting experiments in the laboratory, laboratory models, assessing the functional impact of various drugs and combinations. And then linking all of these together, we plan to use computational integration and data analytics to try and, as I say, untangle why drugs work for certain sarcomas but not for others, and to try and work out what the right combination for an individual patient is. So there are other ongoing trials in the preoperative setting. The MD Anderson team have a phase 2 trial of checkpoint inhibitors, immunotherapy drugs in surgically resectable disease. And the primary aim of this trial is to determine the pathological response, so the response when the pathologist looks under the microscope to preoperative or neoadjuvant treatment with a checkpoint inhibitor, nivolumab as monotherapy, or nivolumab in combination with another checkpoint inhibitor, ipilimumab. And this trial is open to dedifferentiated liposarcoma in the retroperitoneum, and also undifferentiated pleomorphic sarcoma affecting the arms, legs, and chest. And these patients will also receive concurrent standard neoadjuvant radiation. The French sarcoma group also have a preoperative trial called Tornado, which is outlined on this trial. And again, this is open to patients with undifferentiated pleomorphic sarcoma. One of the things to point out regarding the preoperative setting, particularly in the context of Natalie's excellent presentation, is that the preoperative setting allows us to look at the pre-treatment tumor specimen as well as the post-treatment tumor specimen at the time of surgery. So very valuable in terms of trying to understand why certain drugs work and why in other patients drugs are not successful and have no efficacy. So really good that there are so many trials in the preoperative or neoadjuvant setting. And of course, the SARC group led by Denise also have a randomized phase 2 trial of preoperative radiation plus surgery versus preoperative radiation surgery with the checkpoint inhibitor pembrolizumab. And this trial is open to, again, UPS or undifferentiated pleomorphic sarcoma, dedifferentiated and pleomorphic liposarcoma patients. And the primary endpoint of this trial is 2-year disease-free survival, and their enrollment goal is 120 patients. Dr. Haas and colleagues in the Netherlands also have a trial of preoperative radiation, and this is looking at ways to reduce the burden of current treatment, as well as maintaining the effect of radiation in terms of local control rates, and also in terms of the impact in terms of wound complications. And they are looking at short course preoperative radiation in head and neck, extremity and trunk sarcomas. And again, this is a randomized controlled trial looking at 2 different schedules of radiation. So 25 times 2 gray over 5 weeks and 14 times 3 gray over 3 weeks. And the primary endpoint is looking at no increase in major or moderate wound complication rate between these 2 radiation schedules. Moving on to gastrointestinal stromal tumor or GIST, of course, this has been one of the great success stories of oncology in terms of the introduction of imatinib and other drugs that target the activating mutations of KIT and PDGFR alpha in this disease. Unfortunately, for many patients, a resistance to imatinib and the other tyrosine kinase inhibitors develops, and there are a number of very exciting trials looking at newer drugs in advanced gastrointestinal stromal tumor. So this is an outline of the randomized PEAK trial. So this is looking at randomizing patients who've previously been treated with imatinib and allocating patients to either receive sunitinib, the standard second-line drug, sunitinib alone, or the combination of bezuclastinib, a new drug, plus sunitinib. And this trial is currently enrolling all over the world, as you can see on the map on the right-hand side of this slide. So again, a very exciting trial in terms of the hopefully the first trial that will lead to approval for a combination of 2 drugs in advanced gastrointestinal stromal tumor. The primary objective is to determine the efficacy of the combination of bezuclastinib plus sunitinib versus sunitinib alone as second-line treatment in GIST patients. And the primary endpoint of the trial is the progression-free survival based on blinded independent review of the radiology using standard so-called RECIST measurements. So the progression-free survival, the time from starting the treatment to the time that the cancer progresses. But there are a number of other endpoints to the trial, as highlighted on this slide, including overall survival, safety and tolerability, particularly of the combination, and also quality of life and other exploratory endpoints. Another trial in GIST that is ongoing is the INSIGHT trial. So as I mentioned, sunitinib is the approved second-line therapy for advanced GIST after imatinib, but ripretinib, a broad-spectrum switch control inhibitor of KIT and PDGFR alpha, has been approved as fourth-line treatment for advanced GIST by the FDA. In a second-line trial of ripretinib versus sunitinib, there was no difference in progression-free survival between the 2 drugs. There was a good safety profile and a good quality of life associated with the use of ripretinib. And the results of the INTRIGUE trial are shown on this slide in terms of the progression-free survival on the left-hand side, and also the safety profile on the right-hand side. So you can see the two curves on the left-hand side virtually overlap. But there's an interesting subgroup analysis of this trial, an exploratory analysis looking at circulating tumor DNA. And this demonstrated a meaningful clinical benefit with ripretinib compared to sunitinib in patients with concurrent KIT exon 11 mutations plus KIT 17, 18 mutations. And you can see that on the left-hand side of this slide, that the median progression-free survival for patients with this molecular profile when treated with ripretinib was 14.2 months compared to 1.5 months with sunitinib. And this was a very significant result. And the significance of this is also shown on this slide, showing the objective response rates for this molecular cohort of patients. So the response rate for ripretinib for patients with tumors harboring KIT exon 11 mutations plus KIT 17, 18 KIT mutations was over 44% compared to 0% for sunitinib. And this has led to the INSIGHT trial, which will randomize people 2-to-1 to either receive ripretinib or sunitinib with progression-free survival as the primary endpoint. And this slide outlines the design of the trial. So as I mentioned, the primary outcome measure for this trial is progression-free survival by independent radiology review. And this slide shows the eligibility criteria for the trial. So fairly standard in terms of a trial for patients with advanced GIST. There are a number of other exciting trials in earlier clinical development. So as Denise mentioned, there are phases of drug development, and the next two trials are in phase 1. There's a very interesting drug called NB003, which again is a small molecule inhibitor of KIT and PDGFR alpha. It's designed to inhibit a broad range of primary and imatinib resistant secondary mutations. Strong preclinical data supporting its development, and there's a current phase 1 trial evaluating this drug open at a number of sites in America and Europe. Additionally, IDRX42, again, is a novel and very specific KIT inhibitor, very strong laboratory data supporting its use as well. And again, this trial is open at a number of sites around the world. And this gives the design of the trial. So moving on to another relatively common soft tissue sarcoma subtype, leiomyosarcoma. There are a number of interesting trials in development for leiomyosarcomas, and this evening I'm just going to highlight two. The first is a trial of UNESBULIN, randomizing patients 2-to-1 to either receive UNESBULIN plus dacarbazine or placebo plus dacarbazine. And this trial has recruited very quickly. The target number is 345 patients. And the primary endpoint, again, for this trial is progression-free survival. There are a number of secondary endpoints, including overall survival, the response rate, disease control rate, as well as safety and tolerability. And it's likely that this trial will complete recruitment very, very soon. Another trial in development for metastatic leiomyosarcoma consists of the combination of doxorubicin plus lurbinectedin. The outline of this trial is shown on this slide. So this will be open to patients with metastatic leiomyosarcoma, patients with ECOG performance status of 0 to 1, and it will be a first-line trial open to patients, and allocating patients in the first component of the trial to either receive one of two doses, two dose schedules of doxorubicin plus lurbinectedin, and then the standard doxorubicin arm highlighted in red on this slide. There'll be an interim analysis to see which of the combination arms is the best one to take forward to the randomized phase 3 trial, which will then allocate people to either receive the selected combination schedule or doxorubicin 75 milligram per meter squared. And again, the primary endpoint of this trial is progression-free survival. For liposarcomas, and in particular dedifferentiated and well-differentiated liposarcomas, these tumors are characterized by molecular abnormalities of amplification in MDM2 and CDK4. And the Brightline 1 trial has recently closed to recruitment. So this was a first-line trial again for patients with advanced or metastatic dedifferentiated liposarcoma, allocating patients to either receive the MDM2 inhibitor or doxorubicin. And again, the results of this trial are very eagerly awaited, with a strong biological rationale for the use of MDM2 inhibitors in dedifferentiated liposarcomas. In terms of immunotherapy, there are many trials of immunotherapy open to sarcoma patients and open to cancer patients in general. But I want to just focus on one current trial that is for patients with advanced or refractory undifferentiated pleomorphic sarcoma, UPS, or myxofibrosarcoma, MFS. And initially, this trial allocated patients to receive either one checkpoint inhibitor, one immunotherapy drug, envalulimab, or get the combination of envalulimab and ipilimumab. Without going into the detail of the trial now only recruits patients to the single agent arm, and the primary endpoint of this trial is objective response rate by blinded central radiology review. And again, the key secondary endpoints include duration of response, safety, overall survival, etc. This trial is open to patients over the 12 or above. Patients are not allowed to have received prior treatment with immunotherapy, and no more than 2 prior lines of treatment. And the primary endpoint of this trial is objective response rate by blinded independent central radiology review. In terms of other trials, there are a number of interesting trials of PARP inhibitors in various sarcomas, including leiomyosarcomas. And again, the aim of this presentation is just to give an overview and to emphasize to people that there are many trials open to sarcoma patients, which is a really, really good thing. And some of these trials use combination of PARP inhibitors plus chemotherapy or radiation. And again, an outline of some of the currently open trials of drugs targeting DNA damage response in sarcomas. Following on from Natalie's excellent presentation, there is also a current randomized trial for patients with advanced chondrosarcoma, which is a very challenging disease to treat when it is not resectable or it's metastatic. This trial looks at an antibody treatment, an antibody to death receptor agonist 5, and it allocates people to receive either the active drug or placebo. And the primary endpoint of this trial is progression-free survival. So again, the time it takes from starting the drug for the cancer to progress or grow. And this trial is currently open, and hopefully, will provide an effective approved treatment for this disease, which currently we have no effective treatments for. And then finally, desmoid tumors. There's been great excitement regarding the use of gamma secretase inhibitors in desmoid tumors based on strong laboratory data, but also a positive phase 3 trial of the gamma secretase inhibitor nirogacestat, just published in the New England Journal of Medicine. There is another gamma secretase inhibitor in development for desmoid tumor, and that's called AL102. And this trial is currently recruiting patients with desmoid tumor. And again, you can see from this slide that the randomization or the allocation in this trial is to the gamma secretase inhibitor or placebo, with, of course, crossover if there is disease progression on placebo. And the primary endpoint of this part of the randomized part of the trial is progression-free survival. So my conclusions are that there are many promising clinical trials currently open for patients with sarcoma, many trials that are currently recruiting patients, and it's important to talk to your oncologist about entering and participating in a clinical trial. Major thing is that international collaboration in such rare tumors is very, very important, and hopefully that this will all lead to more effective and well-tolerated therapies for patients. And we also need more collaboration between laboratory and clinical researchers so that we have a better understanding of the biology of these cancers, so that we can design better trials and better treatments in the future. So with that, I'd like to say thank you, and hopefully I'm within time, Denise.
Thank you very much, Professor Jones. We really appreciate it. It was really a formidable task to you and Dr. Gaspard to take 20 minutes to cover such a broad landscape. Obviously, sarcomas across many different subtypes. It's not just one disease, but many different subtypes. And you've really given us a insight into what's going on, and that there's a lot of work that's going on and a lot of opportunities for patients to participate in clinical trials and opportunities for us to learn more about how better to treat these diseases. So with that, I'd like to open the floor to questions. And I know that we already do have a question that's been posed by Warren Rice in our chat box. And you asked, Warren, that you noticed that there are a number of trials with doxorubicin and ifosfamide at their core, and maybe adding a third compound. And so given that doxorubicin ifosfamide has limited efficacy for the majority of sarcoma patients and is a very tough treatment on the human body and organs, I have difficulty to understand why there's so much effort and resource spent on trying to improve information about doxorubicin ifosfamide-based treatments, when it could be maybe argued that the resource would be better targeted towards new approaches such as immunotherapy or vaccines that might offer a different opportunity or chance. With that, Dr. Gaspard or Professor Jones, would you like to speak to that, of why this remains kind of a backbone of some of the therapies in the trials?
Yes, so I think that's a really, really good question. Taking a step back, one of the major points for soft tissue sarcomas is that many first-line trials have been performed over the last 15 years, and unfortunately, none have shown a novel combination to be superior to doxorubicin, particularly in terms of overall survival. So we need to sort of build on that. I'm as frustrated as anybody that we're still using doxorubicin as first-line treatment, a drug that's been known to be effective in a way for sarcoma since the 1970s. But the regulatory agencies still consider it as you know, the standard comparison arm. So I think in terms of I think it's important that we do compare to single agent doxorubicin, so that we know that we're doing better. But I fully take your point, Warren. I really want to be in the position where we're using novel drugs for many sarcoma subtypes. But I think for the foreseeable future, for certain sarcoma subtypes such as synovial sarcoma and myxoid liposarcoma, doxorubicin is still going to be the you know, the backbone of treatment. This is a discussion that I have with people in clinic all the time regarding clinical trials, particularly if we know that a subtype's not responsive to doxorubicin, whether it's better to go for a clinical trial first and then to fall back on doxorubicin. But maybe I can hand over to Natalie for her view on this.
Yeah, I think the answer might be different between pediatric type of sarcoma and adult type of sarcoma. In pediatric type sarcoma, you have 80% cure in some patients with that kind of regimen. Then taking them completely out of the treatment is not possible, and doing trials just in a very small population of patients with metastasis makes trial quite difficult and long. In adult, it's a bit different, I think, and Robin has already answered the question. But this brings us back to the biology of the tumor. I'm a bit insistent on that, but probably if we knew better the disease, and now we have the tools to try to do it, which were not probably the case 15 years ago, or even 5 years ago when these trials were set up, we might change the way of doing trials and change the way of asking questions on new drugs. And I think that's very important that now each new trial that is open has biology in it, and not just the medical question, but also sample collection to be able to answer the biological questions.
I totally agree, Natalie. And, you know, that's one of the reasons I think the preoperative setting is so good, because it gives us the tumor material before treatment and the surgical sample after treatment. And it's just one tumor rather than metastatic disease, which can be very heterogeneous in terms of the, well, resistant mechanisms and the biology. So I'm really pleased to see that there are so many trials in the preoperative setting, which I hope will give us more understanding of the biology. And it's interesting that both you and I are on the same page in that respect.
And I think you underline a really important point from a patient perspective, is that when we're looking at informed consents and signing informed consent, oftentimes asked to provide a biopsy or a blood sample. And I think you're both underscoring how important those tests are, to have the tissue and the blood to be able to understand the treatment that's being given and learn more about the biology of the disease. So as you say, Dr. Gaspar, to plan the next studies, right? So that we understand, and as you said, Professor Jones, why something works or doesn't work. So if we get a piece of tissue before you expose it to any treatment of any kind, you understand the disease, then you get another sample after the treatment, then you can understand, well, is it working like we thought it was going to work? Is it acting on the target we thought it was acting on? So really, really important. Thank you. Those are really helpful responses.
It's interesting. This is a discussion that I had in clinic with somebody recently, where you know, we were all really pleased that the treatment had worked within a trial, and we were discussing the pros and cons of doing a repeat biopsy. And you know, the question that I got asked was, well, do we really need a repeat biopsy? And you know, the thing is, well, it would be really helpful, because it would help us to understand why there'd been a response. So it's it's challenging, but I think the preoperative setting, as I say, is the ideal location for collecting this tumor material.
And I think it's helpful for us to understand why that's so important. And so that's where I think patients as partners on these trials, it's so important to understand this. I see there's another question. I don't know, Professor Jones and Dr. Gaspar, are you able to see the chat? There's a question that's been posed to you, Robin, about your opinion about the PUSH project that Dr. Stracciatati had launched at CTOS from Andrea.
Yeah, I'll just get the.
If you can't, I'm happy to repeat the questions. He's just wondering about your opinion about this project.
Yeah, I think this is all really, really good, and I think it comes back to that point regarding international collaboration, that we've got to all work together. And I think Dr. Stracciatati has been just absolutely fantastic in terms of driving many of these projects forward. So I think that is so important, the collaboration and the interaction between different groups around the world, basically. So yeah, I think it's good.
Anthony asked a question about, given the number of trials that have shown or show different efficacies depending upon mutation, what is the importance of mutational analysis being performed, and should it be mandatory?
So I think that GIST, prior to starting systemic therapy or tyrosine kinase inhibitor therapy, yes, I agree. Mutational analysis should definitely be mandatory. And I think the really sort of great thing in GIST right now is that there are so many new drugs in development, but also trials that are exploring the use of combination therapy, as I mentioned, but also the selection of treatment based on the molecular profile of the tumor. So I think it's a really, really exciting time, and we should clearly be doing that for people with GIST. For other sarcomas, the role of sequencing in terms of daily clinical practice, it could be argued, is still remains to be defined. For many sarcoma centers, the pathologist will sequence the tumor anyway, or perform specific molecular tests. But in terms of guiding treatment for most sarcomas, I still think that's a work in progress, and it's important to build again international collaborations, as Natalie highlighted, to sort of try and understand what the role of profiling is in different types of sarcomas.
Thank you, Professor Jones. Dr. Gaspar, in pediatric young adult?
Yeah, I think that we also have to go beyond the mutation, because there are clearly some mutations that are important in some sarcoma, but there are other sarcoma that are fusion driven, or they are not at all mutation driven with very complex genetics. And then we have to envision the molecular profiling in a different way. And it's not just the tumor cells, but it's also the microenvironment that is important. And we are starting to have some data in sarcoma, especially with the TLS, for example, and immune therapy. And probably what we will need to do in the next year is to change our way of doing molecular profiling in patients. And again, thinking not just tumor cells, but thinking also microenvironments.
But again, it comes back to understanding the biology and actually looking deeply into what our treatments are doing to the tumor, or not doing to the tumor. Are the drugs actually hitting the proposed target?
So while we've learned a lot, we still have more to learn. And so there still are many opportunities of analyzing these important tissue samples. It's really critical. And I think, patients giving permission for that is an important part, and seeing how important that can be. Maisie asks about, is there more that can be done to encourage sarcoma centers to explore more neoadjuvant treatment options? And is this what would be preferred? Typically, most undertake surgery first if they can, mainly because the patient would prefer this. And this is addressed to both you, Dr. Gaspar and Professor Jones. What are your thoughts?
I think, again, it's a bit different between pediatric sarcoma and the other ones, because in pediatric sarcoma, it's a standard of care to have neoadjuvant chemotherapy, which is not the case in most of the adult sarcoma.
Yeah, so this is a fantastic question, Maisie, and I think the STRAS-2 trial is going to be really important in this respect. I think there's a lot of variation in terms of using neoadjuvant chemotherapy, and I suppose the evidence base is still challenging regarding conclusive proof for the use of preoperative doxorubicin and ifosfamide. I think as we discussed before, the UK is very much against the use of neoadjuvant and adjuvant chemotherapy for most soft tissue sarcomas, particularly in the context of the two drugs, doxorubicin and ifosfamide, having rare but very serious long-term complications, including but not limited to heart failure, kidney failure, secondary cancers, secondary leukemias that can be very challenging to treat, and of course infertility as well. So I think it's still a very controversial area. I think a number of trials, a number of studies that have been published over the last few years, including the trial led by Dr. Gronke of standard anthracycline ifosfamide chemotherapy versus histology tailored chemotherapy, as well as the use of the sarculator nomogram, have in a way supported the use of neoadjuvant chemotherapy, but it's still a controversial topic, and the serious and potentially fatal long-term complications, even though they're very rare, need to be considered into the discussion if there's no concrete evidence of a survival benefit. All the evidence we have, I suppose, is from extrapolation. So I think that maybe explains some of the reluctance in certain sarcoma centers not to use preoperative or postoperative chemotherapy. But again, I'm very open to to discussing this. I was going to tease Denise a little bit. Denise will be banging the table saying, no.
I'm going to be very neutral.
Thanks a lot. That's really helpful.
Thank you. Nice to see you. Nice to see a lot of other names. I can't see everybody, but it's really, really nice to see all the names on the participant list.
So you both have talked about a number of different clinical trials that are going on. Can you maybe give us some guidance as to when do you consider a clinical trial for a patient, or when should a patient be thinking about a clinical trial might be an option for them? Because it's kind of hard to, we just have a kind of surface level of all the different things that are going on. What guidance might you provide? Who should go first?
Maybe Natalie. I've been talking too much, Natalie, so you tell me to shut up.
But I'm not completely sure I have understand the question then.
Well, so the question is, so when in the course of treatment is a clinical trial, do you think that's something that should be considered for a patient? Or is it always every patient should consider a clinical trial?
Honestly, if you ask me, I will consider it at any time. I think if we want to learn at best to be able to improve treatment, the only way to do it is to do it through clinical trial. I know that it's quite fashion now, the word-based evidence, but still there is some pitfall for that. And for the moment, clinical trial is still the best way to understand what is the usefulness of a new drug or a new combination. The problem is that maybe there is not enough, even if there is a lot of them, there is not enough trial for all the situations that a patient can face. And that's the most problematic thing, is how to know which trial is the most appropriate for you. We need to develop, and there is a lot of effort for that, to try to develop what is what is available across the world and not just in one place, to be able to give all the opportunities to the patients.
I totally agree, Natalie. I have the same approach to, or hopefully always have a clinical trial to offer to patients, and as you rightly say, it's the only way to improve our current treatments. And following on from Warren's excellent question, I think, for certain types of sarcoma where we know when the sarcomas metastasize elsewhere in the body, the standard drugs that we have don't work that well. And in those instances, I think it's always good to discuss that really early with the patient. So I totally agree, and I think this really fits in with Warren's earlier excellent question.
No, and I think it's really helpful for us to hear from you where you see this kind of fitting in, so that as people consider their care and what their treatment may be, this is really, really helpful information. I see that we have a couple of questions here. One is about, is there any science or upcoming clinical trials looking into preventing recurrence or metastasis? And I'm assuming that's in general across all subtypes, in this kind of sense of prevention of recurrence or metastasis. Dr. Gaspar, Professor Jones, your thoughts about that?
I suppose in a way that the trials and the studies in the preoperative or postoperative setting are all also looking at that in terms of preventing the cancer coming back. So that's why I was really encouraged that there are so many preoperative trials open right now, which hopefully will show that these treatments can prevent the cancer coming back. So the answer to that question is most certainly yes. There are trials.
Yeah, I think for me it's the objective of all trials, because what you want at the end is to avoid these recurrences and avoid metastasis, which will be the problem for the outcome of the patient. Then this is the question of all trials, more or less, all therapeutic trials that we have at the moment. But what can be interesting is also to try to understand this recurrence mechanism and a metastatic mechanism that might not be exactly the same, and the metastatic process, and to try to target this metastatic process more precisely, and not just targeting the disease at the beginning or when it's already metastatic.
Thank you. With this emerging artificial intelligence, we have another question about the role that AI can serve in research in sarcomas. And from your perspective, are you seeing that applied at all at this point in some of the research?
So in terms of the Sarcoma Accelerator Consortium, we are going to use artificial intelligence to look at pathological and radiological response. I think it's very interesting and very applicable to those two modalities. So one of the things that really sort of interests me is, the response in retroperitoneal dedifferentiated and well-differentiated liposarcoma, and whether we can use artificial intelligence to, in a way, develop a better way of assessing benefit and response in those tumors, rather than just using the current standard criteria that just measured the longest diameter of the tumor for such complex tumors. Clearly, complex in terms of the the volumetric assessment, I think, and in terms of the different components of the tumor, both high and low grade. I think there's a clear role for artificial intelligence, and I suppose that can be applied to many things in terms of the data we obtain from clinical trials.
I think artificial intelligence is already something that is used in sarcomas. Each time that you are analyzing a cohort of data, a cohort of patients with data, either biological, radiological, pathological data, you are using artificial intelligence. But what is changing now is the way we envision it and the way that we are using it to try to really make a difference in the everyday care of the patients.
Excellent. Are there other questions? We're kind of coming to the close of our time, but I think we have time for another question or so. If somebody has a question, please feel free to jump in or raise your Zoom hand, as Catherine has said. Well, if not, I really want to thank Dr. Gaspar and Professor Jones for really helping us to understand the landscape is full of clinical trial opportunities, which is really encouraging, and helping us to understand a little more in detail some of the challenges that are facing sarcoma, and how clinical trials are going to hopefully help us to better understand the biology of sarcoma and identify better treatments. And I really appreciate all of you who are attending today and for being engaged and asking such excellent questions. I think that's also really very, very helpful. We really appreciate the opportunity of SPAGN to sponsor these knowledge spots so that we can learn more and can see each other virtually and have an opportunity to gather together and learn more. So thank you, Professor Jones and Dr. Gaspar, for your time today and for your incredible insights. We appreciate it. Thank you.